Hello, and thank you for joining the National Lupus You event hosted by the Lupus Foundation of America. Our program will be focusing on family planning and pregnancy. Next. This is an overview of our program, and so I will be sharing more about the Lupus Foundation of America, some helpful resources and ways you can get involved. And we are also so honored to have tonight's speaker. So my name is Ashley Holden, and I will be your host or your moderator for this Lupus You event. Next slide. So before we get started, I do have a few housekeeping items to go over. So if at any time you have a general question that you would like to submit to our speakers, you can send it through the Q&A function at the bottom of your screen. Just click on it and type in your question. You should have an option to submit your question anonymously if you don't want your name attached to it. And you can check that when you submit the question. We do have time allotted at the end of this program for Q&A, so I'm hoping that we'll be able to get to all of your questions. I know that sometimes we're just not able to, but we hope to get to as many as we're, hope to get to as many as possible. And then we also have opportunities for you to interact with us and each other. So throughout the program, we have some poll questions. You can also connect with each other in the chat. And I already see some of those chats going through and people saying where they're located, which is great. And then finally, just a reminder that this program will be recorded and you'll receive a link of the recording along with helpful resources, a post-event survey where you can submit feedback about tonight's program. Next slide. So as I mentioned, I'll be talking a little bit about the Lupus Foundation and some of our resources and programs. So first and foremost, our vision and our mission. So the Lupus Foundation of America works to meet the diverse needs of all people with lupus. And our commitment has never wavered in our over more than 40 years of service. Today, people with lupus are living longer, healthier lives than ever before. And the Lupus Foundation of America has played a significant role in that achievement. We remain resolved to doing everything we can to help you navigate the complexities of lupus while rallying every possible resource to end it forever. To put this simply, our goal is to one day end the impact of lupus and its suffering while ensuring that we provide the comprehensive support and programs people with lupus need today. So our programs stand upon three pillars: research, care and support for people affected by lupus, and advocacy. We have redefined lupus research to expand our efforts beyond just funding research grants. We are engaging all stakeholders to identify barriers that stand in the way of progress and setting course to overcome them. And we do this while providing caring support for people affected by this devastating disease and leading the advocacy efforts to bring more funding for research and services. Our approach is comprehensive and focused on achieving meaningful results that will make a difference in the lives of people affected by lupus. To that end, we align our efforts and resources towards achieving 4 specific outcomes. So we want to improve early diagnosis of lupus by increasing awareness of symptoms and educating health professionals so people with lupus get prompt care and treatment. We want to secure new, safe, effective, and tolerable treatments for lupus by advancing research, improving how new treatments are evaluated, and educating people about clinical trials. We want to expand direct services and increase access to treatments and care by providing resources and advocating for improved health services and affordable medications. And finally, raise money and secure government funding to operate programs that help people affected by lupus. People with lupus represent the heart and soul of our organization. You are the central focus of everything we do. You are a constant reminder of our mission's urgency to serve, to motivate us, and to continue this fight. We understand the emotional turmoil, economic hardships, and physical suffering caused by lupus. We get it. Because of you, we are motivated to work harder and faster to bring lupus under control so everyone can have a life free from lupus. As I mentioned, I'll be talking about some of our programs and services. So I wanted to share about RAY, or Research Accelerated by You. We've made significant progress in lupus research, but we are far from over in our quest to solve this cruel mystery. And researchers need your help. You can help advance lupus research right from the comfort of your home. You can participate in RAY, our online research platform. Share your experiences with lupus to help inform future clinical trials of new lupus treatments and identify the most pressing needs of people with lupus. No one understands lupus better than those living with it. So you can compare your experiences with others. You can get updates on new research studies, share your medication and health information with your doctor, and help brighten the future of lupus research. We have so many other programs and resources for you. We have numerous support groups across the country where people with lupus can come together, and many of those are meeting virtually at this time. So I encourage you to check those out and see if there's maybe one that you would like to join. You can also join Lupus Connect, which is our online support community where members can engage and ask questions. And we also have the Expert Series, which is our monthly educational podcast from lupus experts. And so make sure you check out those monthly episodes that we put out there. We also have our National Resource Center on Lupus, and that's your one-stop resource for all things lupus. From treatment to living and coping with the disease, it aims to ensure that anyone affected by lupus, including people diagnosed with lupus, caregivers, and healthcare professionals, have access to high-quality resources that provide clear and accurate health information. We know how important that is and how hard it can be to find that accurate information in the wealth of the internet. We also have a team of health education specialists. Our health education specialists are specially trained to provide people affected by lupus with non-medical support, disease education, information, and helpful resources. Some of our health education specialists are working behind the scenes tonight during the event to help answer the questions in the Q&A box as well. I also want to mention that we have 2 bilingual health educators that both speak Spanish too. And then we also have Take Charge, and that's our 12-week email series designed to provide information, tools, and resources to help you better manage living with lupus. There are also a lot of different ways that you can get involved and help support the fight to end lupus. So we have had Walk to End Lupus Now events taking place across the country this fall. And whether you participated at an event or virtually in your community, make sure to attend our virtual walk celebration, which is coming up on November 17th. We have Make Your Mark, and that's our community fundraising program. It's a way to turn an event into a fundraiser for lupus. You can use your passion to raise funds for lupus through an in-person or virtual event. And then finally, Your Voice is an advocate for lupus, and it's one of the most powerful tools that we have. So we are the leader in stimulating federal support for lupus, generating more than $615 million for lupus research and education in the past 5 years. Every day, we fight to ensure that the government is responsive to the needs of the 1.5 million Americans living with lupus. You can visit our website to sign up to become a lupus advocate. So we have our first poll question. We'll wait for that to pop up. So the first question we have is, true or false, there are safe and effective birth control options for people with lupus? And the options are true, false, or I'm not sure. And we'll take, let's say, about 10 to 15 seconds to answer that. Just a few more seconds, and we'll go ahead and close out that poll. Let's look at those results. Can we get the results for the poll? There we go. So 81% said true, 1% said false, and 18% are not sure. So I know our speakers will cover this in just a little bit. We can go ahead to the next slide. So now we have our motivational moment with Dr. Joy Buie. And Dr. Joy Buie is the Director of Research at the Lupus Foundation of America, where she directs programs and projects that bring together world-renowned experts to solve the cruel mystery that is lupus. Joy earned her PhD, Master's in Clinical Research and Bachelor of Nursing degree at USC, where she honed in her research skills. Joy is the author or co-author of over 15 academic publications and the recipient of numerous academic awards and grants. And she has also lived with lupus for 19 years. Like many patients, when originally diagnosed, Joy was quite pessimistic about the idea of having children while living with lupus. Tonight, she'll be sharing her challenges and triumphs on her journey to motherhood and beyond. So thank you so much for joining us, Joy.
Thank you so much, Ashley, and good afternoon and good evening to everyone. I ask that you give me space to take off my professional hat and put on my patient hat this evening as I share my story about my pregnancy journey. On October 31st, 2015, at approximately 5 a.m., I was sitting in my designated meditation space in my house in Charleston, South Carolina. I began to have visions of children playing in the hallway. And as I opened my eyes, I wrote down a few notes in my journal, specifically the month and year I expected to conceive, which was April 2016. And based on that timeline, I wrote down the month and year my child would be born. Now that I look back on it, it was rather bold of me to believe that something like that could happen in the order in which I'd arranged it, but I didn't always have that boldness. Like many of you in the audience, I was once in a place along my lupus journey where I thought having a viable pregnancy was out of the question. From my perspective, there were so many hurdles to jump, too many mountains to climb, and valleys that were just too deep to overcome. So what changed? Well, this evening, I'll take the next 9 minutes to tell you, along with providing some insight about my personal journey to motherhood. I would be remiss if I didn't start off this talk by first honoring my husband, who is not with us tonight because he's caring for our beautiful baby girl, but also I want to acknowledge my Lord and Savior, Jesus Christ. Without him, none of this would have been possible. So back to my original question, what changed? I've always been a highly analytical person who does insurmountable amounts of research to understand why things happen. So much so that I decided to get a PhD studying lupus because my naivety made me think that I'd be able to save all of us by curing lupus. Needless to say, I haven't quite figured it out yet. My deep analytical thinking didn't necessarily work in my favor when I had the strongest desire to become a mom, but couldn't get over the what ifs. Like, what if my kidneys fail? Or what if my lupus flares? Or what if I have a stroke or develop heart disease during my pregnancy? Or what if I develop eclampsia? Or what if the baby comes out deformed or intellectually challenged? Or what if I give the baby lupus? Or what if I die and leave my husband and family heartbroken? I'm sure at least some of you have had these thoughts before too, when considering pregnancy while living with lupus. In order to change my situation, I first had to change my mind. At the church I attended, there were several young women that I befriended who, unbeknownst to me, would have their own struggles with pregnancy and childbirth that would serve as my examples of what I considered to be modern day miracles. I had a friend who was an OBGYN but struggled to have children of her own, even though her job was helping other women have children. And after 3 miscarriages, she ended up giving birth to 2 healthy baby boys. I had another who had a healthy pregnancy, but afterwards ended up with a thromboembolism, and the doctors at the time said that she'd have to relearn how to walk and talk, but she came out unscathed without going to rehab or therapy when she was released from the hospital. It was seeing those miracles that happened for these women that made me believe that it could happen for me too. Next slide. I approached my rheumatologist about my desire to have a child in September of 2015. Because my lupus was in remission for a while, she thought it'd be a good time to try. So we started the process. The first thing I had to do was get off medications that I couldn't be on when conceiving. And so the first to go was Myfortic. Some of you might know that medication is Celsep or mycophenolate mofetil. I'd been taking that medication for the lupus that was in my kidneys or lupus nephritis. And my rheumatologist wanted to monitor me for 6 months to make sure I remained stable before getting pregnant. After 3 months of being off the medication, I decided to take some additional steps to make sure that I was positioning myself to be in the best shape possible for both me and my unborn child. Next slide. So I decided to join a fitness program at my local gym called the Healthy Charleston Challenge. Pictured here are my two trainers, Coach Koo and Coach Lily. It was Coach Koo who would teach me about different dietary changes that I could make that would change the trajectory of my life. And so while she gave us a list of things that we should be doing that we coined as Koo's rules, there were 3 things that I thought were imperative to improving my overall health and helping me lose 30 pounds within 10 weeks. Now, I don't encourage anyone on the call to engage in a weight loss program without first talking to your doctor, because some of you may not even need to lose weight, but I did. And so she talked a lot about salt restriction, increasing water consumption, and minimizing the intake of processed foods. In fact, she told us not to consume foods that had more than 5 ingredients on the nutrition label. And come to find out, her mother also had lupus, and so she understood the struggles that I was dealing with. So in that short amount of time, I was able to get off additional medications that I couldn't be on while conceiving, such as blood pressure medications. And so, next slide, please. After going through that program, I talked to one of my really close friends who was the OBGYN about different options in the area for a maternal fetal medicine physician, or MFM, because people who have lupus and other chronic illnesses must be seen by a specialized OBGYN for their care when considering pregnancy. I'd even asked her to take me on as a patient, but she refused and instead sent me to her mentor. And so Dr. Johnson did a workup on me specifically for people with my condition, with lupus. And everything that was supposed to be positive came back positive, and everything that was supposed to be negative came back negative. And in fact, she told me that she'd never seen someone who had worked as hard as I had to prepare for pregnancy. And she also said that she hoped I came back pregnant with twins. Next slide, please. So in April 2016, we conceived, and I found out on May 8th, 2016, which was Mother's Day. So many thoughts ran through my mind. What happens next? When do I need to go to the doctor? Do I need more blood work? Is the medication affecting the baby? Is the medication affecting the baby? Is the medication affecting the baby? I no longer cared about me. Everything was all about the baby now. Next slide. The first trimester, I was pretty tired, but the lupus didn't flare. The second trimester was fine up until about 6 months when things began to change. I started spilling protein in my urine, which gave the doctors cause for concern. They added a small amount of prednisone to my regimen and reassured me that the small amounts had a high benefit to harm ratio, meaning that it was better for me and the baby to take it rather than not take it. In addition to that, my blood pressure started to go up later on in the second trimester, and my MFM made an executive decision to put me on bed rest in addition to adding labetalol to my medication regimen, which was a safe blood pressure medication that I could take during my pregnancy. And while I didn't have activity restrictions, she wanted me to stop working because she felt like it was just too stressful for me to be in an environment where I was a postdoc doing research for 12 hours a day. And so I went home and I sat down and I rested and I did everything that I could to make sure that me and the baby would be healthy in the end. But during the third trimester, things got really tough. I had several different hospital scares. I had to be monitored twice a week so that they could make sure the baby was still developing like it needed to, but also that it was still moving normally. And after having several scares, she decided to go ahead and induce me at 37 weeks and 2 days. Next slide. So Faith was born December 23rd, 2016, after 25 hours of labor and ultimately a C-section. She was 6 pounds and 1 ounce and roughly 19 inches long. Next slide. Following her birth, I made a decision to breastfeed. And so I met with a lactation consultant and she encouraged me to pump and dump because I was still taking certain medications that could potentially pass through the breast milk. And so just to be on the safe side, she encouraged me to do that. However, a month later, because my blood pressure issues hadn't resolved and my kidneys were getting worse, the doctors decided to put me back on mycophenolate mofetil or Myfortic. And so I dealt with postpartum depression for about 2 weeks because of that, because I wanted to breastfeed because you've heard the messages before, breast is best, but my MFM reassured me that fed is best. And so I decided to move forward with formula. So the questions about whether or not my child was going to be okay, if she was going to have intellectual difficulties, all the things that I was worried about, including my own health, were viable concerns, but nonetheless, nothing bad ever came to pass. And in fact, my child was reading when she was 3 years old. I got a message from her teacher the other day saying that in her 21 years of teaching, she's never had a child that was so sweet, considerate, and smart. And so everything worked out well in the end. Next slide. And I'll take any questions that you have at this time.
Thank you so much, Joy. I know I have chills listening to you speak, and we appreciate you sharing your personal story with us. I don't see any questions at the moment, but I know that we'll have our Q&A at the end as well. So if anybody thinks of anything, we can ask Dr. Buie at that point too. Great. Well, again, thank you, Dr. Buie. And then we have our next poll question for those of you that are with us. We can go ahead and get that popped up. Okay, so the question that we have is, what topics are you the most interested in learning more about from our presenters? And you can pick all that apply here. And the options are contraception, timing of pregnancy, medications in pregnancy, lupus impact on the reproductive system in women, lupus impact on the reproductive system in men, and then pre and postpartum care. Again, we'll take about 15 seconds to answer this poll question. Okay, we can go ahead and close the poll and we can take a look at those results. Okay, great. So it looks like we have a lot of people respond here. So 22% of our attendees are interested in learning about contraception. 54% are learning about timing of pregnancy. 68% are interested in medications and pregnancy. 78% in lupus impact on the reproductive system in women. We do have some people for lupus impact on the reproductive system in men at 11%, and then 65% for pre and postpartum care. Well, thank you all for participating in our poll question. I can go ahead and move to our next slide. So our next speaker is going to be Dr. Bonnie Bermas, and she is a professor in the Department of Internal Medicine at UT Southwestern Medical Center. She specializes in rheumatology disorders. Dr. Bermas earned her medical degree at the Mount Sinai School of Medicine, where she was elected the Alpha Omega Alpha Honor Society and completed a residency in internal medicine at New York Presbyterian Columbia University Medical Center. Drawn to immunology and autoimmune diseases, she then pursued a fellowship training in rheumatology at Brigham and Women's Hospital in Boston and at the National Institutes of Health. Dr. Bermas is certified by the American Board of Internal Medicine in Rheumatology. She joined the UT Southwestern faculty in 2017. Prior to joining UT Southwestern, Dr. Bermas was the clinical director of the Lupus Center and co-director of the program in pregnancy and rheumatic diseases at the Brigham and Women's and Harvard Medical School. Dr. Bermas was previously a board member of the Lupus Foundation of New England. She is a member of the American College of Rheumatology, or ACR, where she was part of the core writing committee for the recently published guidelines for the management of reproductive health in rheumatic and musculoskeletal diseases. She was also part of the ACR task force for the management of rheumatic disease patients during the COVID-19 pandemic. In 2012, she earned the National Health Information Bronze Award from Arthritis Self-Management magazine. Her research interests include pregnancy and rheumatic diseases, systemic lupus erythematosus, and antiphospholipid syndrome, or APS, and rheumatic immune checkpoint inhibitor adverse events. She has delivered numerous international and national invited lectures, contributed to books such as Systemic Lupus Erythematosus, and published a number of academic articles. And we are so honored to have you with us this evening, Dr. Bermas. The floor is yours.
So thank you so much for the kind introduction, and to the Lupus Foundation of America for inviting me to participate in this wonderful program. I also want to thank Dr. Buie for her really inspiring story, which as a person who really works with patients with lupus, I think she really captured all the highlights, all the struggles, and thank all of you for attending tonight. So next slide, please. Next slide. Now, I saw the poll thing. I'm a little nervous because each one of these topics could be a good hour lecture itself. So we're really going to be like when you go to a buffet and you take a little taste of a bunch of things. I'm going to go over some topics in contraception, pregnancy planning, pregnancy management, and lactation. Next slide, please. So I'd like to start with a case. This is an 18-year-old woman who comes to see her rheumatology provider. Shauna's had a history of lupus. It was diagnosed at 12 when she presented with renal disease. Currently, she's in remission and remains on hydroxychloroquine. And one of the most important things that we as providers should be doing when we speak with our patients, and our patients hopefully will talk with us about, are illustrated in the next slide. So the one key question, one of the most important things you can talk about with your provider, and we should be talking about with you, is the major question: do you want to become pregnant in the next year? So if that answer is yes, then we can talk about all the things that need to be done preconceptually, just like Dr. Buie talked about. If that question was no, then we need to talk about contraception. I'm going to spend the next few slides talking about contraception, emphasizing why this is such an important topic for rheumatology patients, and in particular patients with lupus. Next slide, please. So why is contraception so important in rheumatology and in our lupus patients? Well, what we really want to do is we want patients to conceive during or get pregnant during a time when their disease is well controlled and they're on medications that they can continue during pregnancy. Pregnancy's outcomes are better when disease is not active at the time you get pregnant, and we want to hopefully prevent unplanned pregnancies. Next slide. The reason why is not only because the pregnancy goes better if disease is under good control, but some of the medications we prescribe and use in treating our patients have teratogenic potential, which means they can cause birth defects. So things like methotrexate, or as Dr. Buie talked about, mycophenolate mofetil, or lofalidomide, or cyclophosphamide. These are all medications we want to avoid during pregnancy. Next slide. So also in this day and age, with stricter abortion legislation, effective contraceptive counseling is imperative, because in some states, and I'm going to show you a slide of in the United States now, abortion or pregnancy termination is no longer available, which means that patients who may have been exposed to a medication that could cause birth defect in a developing fetus, as well as patients who are really too sick to safely carry a pregnancy to term, may not have the option to terminate the pregnancy anymore. Next slide. So what I would suggest is for providers and for patients, discuss contraception with your rheumatology provider. When we wrote the reproductive guidelines, we had patient participants who were on the guideline writing committee, and they really wanted their providers to talk about family planning early and often. Surveys looking at women with rheumatic diseases regarding contraceptive-related experiences and decision-making processes, patients' decision to use contraception are influenced by their rheumatic disease diagnosis. And some women felt that hormonal contraception was unsafe in the context of their disease, which is not always the case. And contraceptive prescribers, so it may be the person that the patient is going to get their contraception from, may not be familiar with rheumatic disease specific health concerns. Next slide, please. 45% of pregnancies in the United States are unintended, and we don't do any better with our lupus patients. 5% of reproductive age women have an unintended pregnancy each year, and in 2011, 42% of unintended pregnancies ended in abortion, 58% ended in birth. Next slide, please. So what's very important when we talk about contraception is we need to understand patients' values. We need to know how effective the contraception is. We need to know how easy it's going to be for the patient to be adherent to their plan. And it really needs to be shared decision-making between the patient and their provider. Next slide, please. So there are various contraceptive types, and just to show you that this is from the least effective on the bottom of the slide going to the most effective. And I'm not going to go into details on all the different types of contraception, but what I would say is to recognize there are several different choices. Next slide. So this is, by no means do I need you all to know what's on the content of this slide, but this is from our reproductive health guidelines. And I just want to make the point for those patients with lupus, there are two really important steps. One step is to assess people's antiphospholipid antibody status, because if people have coexisting antiphospholipid antibodies, they should avoid estrogen containing contraception. If you don't have a positive antiphospholipid antibody test, as long as you don't have lupus, or you have lupus that's really low disease activity and not moderate disease activity, you really can use most forms of contraception, with the exception of the estrogen patch if you have lupus, because it has very high concentrations of estrogen. If you have high disease activity in your lupus, we don't have information on whether or not estrogen-containing contraception is safe. So we recommend that people avoid it. But there are still many other types of available effective contraception, such as IUDs, progesterone implants, progesterone-only pills that are compatible for patients who have lupus. Next slide, please. So just to sum up for contraception in lupus patients, make sure that your antiphospholipid antibodies are checked. Estrogen-containing contraception can be used in mild lupus with negative, or patients who have negative antiphospholipid antibodies. Contraception does not affect lupus disease activity in those with mild to moderate disease. And as I said, we don't have data on estrogen-containing contraception in severe lupus, but we do have plenty of very effective methods. Okay, next slide, please. So what happens if you happen to have unprotected intercourse, or you have an unintended pregnancy? In the case of unprotected intercourse, there is emergency contraception, and I'm going to talk about that in a minute. There is state-by-state availability of pregnancy termination, And I just want to make the point, there's no medical contraindication to pregnancy termination in women who have lupus, meaning it is not unsafe to undergo any less safe than it is for any other person to undergo a pregnancy termination. Next slide, please. So this is the emergency contraception. This is available and it's effective only before pregnancy is established. And it is safe in women who have lupus with or without a positive antiphospholipid antibody, and it does not exacerbate disease activity. One of my colleagues now is actually counseling her lupus patients to keep a supply of Plan B, our emergency contraception, on hand at home in case of inadvertent unprotected intercourse. Next slide, please. This is what I want to show you is the map of areas of abortion restriction. Currently, this is from mid-October in the United States. Those states that are maroon in color, these are the most restrictive states, including the state I'm in, Texas. And you can see there are others that are very restrictive or restricted. And it's really only in the blue states where they are protecting abortion rights. So it's important that you know where you live and what your access is to pregnancy termination in case that is something you a situation arises that you are considering. Next slide, please. Okay, so Shauna's now 27. She's finished law school. She'd like to become pregnant. Her lupus kidney disease flared during college. She's been in remission for 4 years, and she's currently being treated with hydroxychloroquine, mycophenolate mofetil, and lisinopril. So similar to the story that Dr. Buie told us. Next slide, please. So what do we all want to know? What do I want to know as a provider? What do you want to know as a patient? You want to know if my lupus is going to impact my fertility. You want to know, will your lupus flare during pregnancy? Will my disease cause me to have a worse pregnancy outcome? Will my disease cause the developing fetus infant to have a worse outcome? And what medications are safe to take during pregnancy? And can I breastfeed? And what medications are safe to take during breastfeeding? Next slide, please. So as Dr. Buie told us, we really want patients to have disease in good, in remission or low activity, because that's your best chance of the best outcome. It's best to have management by rheumatologists and either an obstetrician or a maternal fetal medicine specialist, somebody who has comfort level and experience caring for people with lupus during pregnancy. And the important thing is to transition patients to pregnancy compatible medications and observe for a period of time. No one knows what that magic number of period of time is, but I like to observe my patients for somewhere between 4 and 6 months on a pregnancy compatible medication to make sure that they're doing okay and not flaring. So what do I mean by that? Well, supposing I had a patient who was on the mycophenolate mofetil, and I thought she still needed some immunosuppression to safely take care of her disease and get her through a pregnancy. I might transition her off the CellCept or mycophenolate mofetil, put her on a medicine like azathioprine, which is another immunosuppressive agent, which is compatible with pregnancy, and then watch the patient for several months to make sure that her disease still remains in remission. Next slide, please. So when people ask me, how is my lupus going to do during pregnancy? There's not really one answer for all patients with lupus. Some patients have very mild disease, maybe they have some skin disease, some other things, and they can just sail through pregnancy. Other patients may have very active disease, lots of prior history of lupus kidney disease, and they may have a tougher time during pregnancy. Next slide, please. So the risk factors for flares during pregnancy are active disease at conception, kidney disease ever, a history of pulmonary hypertension, first-time pregnant women, prior history of preeclampsia, and discontinuation of your hydroxychloroquine. So we really like patients to stay on their hydroxychloroquine if that's a medication they can take. Next slide, please. So this is probably the trickiest topics, medications in pregnancy. And I'm just really going to try and make this simple for all of you. Okay, next slide, please. You can take most of your lupus medications during pregnancy. I'm just going to correct that. It should be non-steroidal through week 20 because there's now some evidence that it can cause low volume of fluid in the uterus. And so now we say the non-steroidal should be stopped at week 20. What you can't take is methotrexate, leflunomide, cyclophosphamide, mycophenolate mofetil, also myfortic, and thalidomide. But most of the many of the medications that you take to manage disease can be continued during pregnancy. Next slide, please. And other medications can be continued through conceptions, things like belimumab and rituximab, abatacept, which are also used to care for lupus patients. Those antibodies will not cross the placenta until about week 15 of pregnancy. And so they can be continued through conception. The smaller molecules, which are used rarely, but are being used to manage lupus, cannot be used. Next slide. So Shauna gets pregnant. We switch her to azathioprine, continue her hydroxychloroquine, take her off the lisinopril and put her on another blood pressure medicine, observe her for at least 3 months, and then allow her to conceive. Next slide. Happily, she gave birth to a healthy baby girl, Ruby Luna. She now wants to breastfeed, but has questions. What medications can I take while I'm nursing? Next slide. You can take non-steroidals, your Plaquenil, your sulfasalazine, colchicine, baby aspirin. Next slide. And in fact, you can continue many of the medicines you use for the treatment of lupus. Next slide. And the only thing you have to remember is this list of medications that are not compatible with lactation, which is the same list that is not compatible with pregnancy. So methotrexate, leflunomide, mycophenolate, cyclophosphamide, and the small molecules. I do want to make one final point though. Next slide, please. Breastfeeding, and we do encourage, for all the reasons Dr. Buie said, we try to encourage patients to breastfeed, but not every woman is meant to breastfeed, nor is that the right circumstance for everybody. And the most important thing is that a mother feels well and she feels comfortable bonding with her baby. Look at Dr. Buie's daughter's total superstar. So the most important thing is that you feel happy with the decision you're making. You're feeling comfortable bonding with your child, and your health is good during that postpartum period. So I think I'll stop there. Next slide, please. And I can answer some questions at the end, I think, during our panel discussion.
Thank you so much, Dr. Bermas. That was such great information. And I know that we could have listened to you speak all night on those topics. We really appreciate you joining us. So next we will have Dr. Salmon, and she will be talking about what's on the horizon, new drug developments. And Dr. Jane Salmon is the Colette Keene Research Professor at Hospital for Special Surgery. She is Professor of Medicine and Professor of Medicine and Obstetrics and Gynecology and Associate Dean, Faculty Affairs at Weill Cornell College of Medicine. Dr. Salmon graduated magna cum laude from New York University and earned a medical degree in 1978 from the College of Physicians and Surgeons of Columbia University, where she was the first woman enrolled in the medical scientist training program. She completed training in internal medicine at the New York Hospital and in rheumatology at the Hospital for Special Surgery, where she currently conducts clinical and basic research studies and practices rheumatology. Dr. Salmon has served on the board of directors at the American College of Rheumatology and Rheumatology Research Foundation. Dr. Salmon was the co-editor of Arthritis and Rheumatism and is currently an associate editor at the Annals of Rheumatic Diseases. At Hospital for Special Surgery, she is a director of the Lupus and APS Center of Excellence, co-director of the Mary Kirkland Center for Lupus Research. Dr. Salmon's research has focused on elucidating mechanisms of tissue injury in lupus and other autoimmune diseases. Her basic translational and clinical studies have led to a paradigm shift in the understanding of mechanisms of pregnancy loss, cardiovascular disease, and end organ damage in patients with lupus. She identified the critical role of inflammation as a mediator of placental insufficiency and defined new treatment targets. And so we are absolutely honored and very excited to hear you speak this evening. Thank you so much.
Thank you for the lengthy and extensive introduction. I'm delighted to be here, and I hope that what we're doing in research engages you, excites you, and allows you to see the promise of. I have the next slide, please. So you've heard from Dr. Bermas and from Joy that pregnant women with lupus have higher rates of preeclampsia, fetal and neonatal death, and fetal growth restriction. And a key piece of data to develop treatments and prevent poor pregnancy outcomes is to understand how they occur and why they occur. What are the mediators and mechanisms at the maternal fetal interface that are causing the problem? And I always have this image of a painting by Gustav Klimt at the MoMA in New York, because it's what it must feel like to be a patient with lupus who's concerned about the potential problems in their pregnancy. And what I hope you'll see today from the science I present is that there's a lot of optimism on the horizon. I have the next slide. Actually, in the chat, someone asked questions about maternal and fetal outcomes in pregnant patients with lupus. And these are data from what's called the United States National Inpatient Sample Database. So insurance companies and hospitals dump their data, de-identify, to look at different endpoints. So here you can see results from 1998 to 2015, if you look at the y-axis, the x-axis, of 78 million pregnant women who didn't have lupus, and 93,000 patients with lupus over this 17-year period of time. And you can see in the lupus patients by the red line, the mortality of women with lupus has really gone down. It was quite substantial about 20 years ago. Mortality of the baby, fetal mortality, has also gone down, and it's getting closer to those without lupus, but there's still a 2 to 3-fold difference in fetal mortality. On the other hand, is not improving. It's still more than 2 times, close to 3 times the frequency of the normal population. And what's interesting is that even in non-lupus patients, preeclampsia is going up, and there are many, many reasons for that. And I think Joy told you a little bit about her experience with preeclampsia. Can I have the next slide? All of the pregnancy complications that occur in lupus patients, placental insufficiency, fetal growth restriction, pregnancy loss, hypertensive disease of pregnancy, and preeclampsia. Next slide. They're all highly associated with the presence of antiphospholipid antibodies. So we created a mouse model to try to get a grip, to try to get an understanding of why antiphospholipid antibodies in lupus patients cause pregnancy complications. The first thing we did was we take a pregnant mouse and we injected it with antibodies, IgG, from a healthy person. And the little image that looks like beads, pearls on a necklace, that's what a mouse uterus looks like that's pregnant. Each of those little beads is a fetus that would be born. Mice have many, many pups. If you inject a pregnant mouse with antibodies from a lupus patient with high titers of antiphospholipid antibody. The little circles are smaller, so there's growth restriction. And some of the fetuses die. They're resorbed, they're non-viable. So we were able to recapitulate what's seen in some patients with lupus, growth restriction and fetal death. And by manipulating mice and blocking a wide range of inflammatory pathways, we were able to understand what are the key mediators of damage. And in fact, we were able to prevent them. If you knock out the gene that encodes for the inflammatory mediator and give the mouse the antiphospholipid antibodies, the pregnancy is viable and you don't have complications. The mouse inhibitors to blockers of TNF alpha, many of which are available in the many diseases, for rheumatoid arthritis, for psoriasis, for inflammatory bowel disease. You can rescue that mouse's pregnancy. Can I have the next slide? So we had therapeutics that worked in mice. How do we translate those findings to people? Everyone says we're not curing mouse pregnancy. What can we do to impact pregnancy outcome in women? Well, the first thing we had to do was we had to identify who was at high risk and who wasn't. You heard from Dr. Bermas that patients with quiescent disease who don't have renal disease are less likely to have complications than those patients who are active. And there are many other features. Antiphospholipid antibodies are also risk factors, as I said earlier, for poorer pregnancy outcomes. But we wanted to really have a risk stratification model so we could identify patients most likely to have problems. And those were the patients we could use in a clinical trial to try to prevent those problems. Can I have the next slide? So that study to develop the predictors was called the PROMISE study. Predictors of pregnancy outcome, biomarkers, and antiphospholipid syndrome and systemic lupus erythematosus. It was a multi-center prospective. That means we saw patients from the beginning of pregnancy all through the end. We saw each patient. We didn't go through charts. We touched each patient. And we observed them. We didn't intervene. We didn't change their care. We just followed them every month, asked them questions, looked at their records, got blood tests. And we enrolled 775 patients, ethnically diverse, multi-center throughout the United States, and it took us 10 years. It was funded by the NIH. Can I have the next slide? So what did we learn from PROMISE? And that relates to another question I think I saw in the question and answer. What are the maternal outcomes of patients? This enrollment was, say, in the last 5 years. So it's in your lifetimes and right now when you're thinking about these kinds of questions. All the patients enrolled had quiescent disease. They were on less than 10 of prednisone, and their disease was inactive. 20% of them had flares. Those had mild and moderate flares. Those flares required no treatment. So these were really trivial. They may be a little bit of a rash or an ache. We didn't have to intervene. They didn't progress. They didn't become worse. 6% of the patients had more serious flares that needed interventions, but the interventions might be steroids. They weren't any really serious flares in the sense that they were serious, they needed intervention, but they weren't life-threatening and they did not influence the pregnancy adversely. So when your disease is quiescent, your pregnancies are likely to be okay. Fetal, the lupus patients, and this is nearly 400 because we had patients who only had antiphospholipid antibodies in PROMISE. So of the lupus patients, 19% of them had an adverse outcome. 4% had a fetal death, 1% had a neonatal death, 8% had a preterm delivery, and 10% had small for gestational age babies. Can I have the next slide? So what were the risk factors? Adverse events. So of the 385 patients, 73 patients had one of the adverse events. and non-Hispanic white is protected, and we really don't understand that. It doesn't have to do with access to care. It doesn't have to do with missed visits. It may have to do with poverty, stressful environments, violence, lack of education and understanding. We don't really understand. It may have to do with the genetics and the vasculature. There's more hypertension in non-white individuals, but it's something to be aware of and to try to study more. If the patient was ever on an antihypertensive medication, if they have a history of high blood pressure, they were not hypertensive when they enrolled in Promise. They were all on medications if they needed them. But if you are on an antihypertensive medicine, you have a 7-fold increase in having an adverse outcome. If your platelet count was low, it had a little negative effect. If you had a lupus anticoagulant, which is one of the antiphospholipid antibody tests, that was the greatest risk factor for an adverse event. And if the physician global assessment, that means the doctor's gestalt, the doctor's general feeling, is your disease active or inactive? But remember, I said the Promise patients had inactive disease relative, but you may have a slight increase. So none of them were really sick with their lupus, but if they had a slight, a little bit of arthritis, a little achiness, and their doctor was concerned, that increased their likelihood of an adverse outcome. Can I have the next slide? So what did we learn from Promise? We learned that patients with stable inactive disease can be reassured that in the absence of any of the risk factors I mentioned, their outcomes are favorable. In terms of the numbers, if you don't have any of those risk factors, your likelihood of an adverse outcome is no different than a healthy lady walking down the street. So that should make people calm. Very high risk, that means having multiple of the outcomes I talked of, the characteristics I talked about. And you might consider an interventional trial or close observation by your physician and minimize some of the factors like aggressive blood pressure control, weight control, and so on. The next slide. So we know who's at high risk, and we know that TNF blockers prevent adverse outcomes in mice, either with preeclampsia, with potential fetal loss, or growth restriction. So now we want to translate those findings to patients. Next slide. And that's the IMPACT trial, improved pregnancy outcome in APS, and the patients can or cannot have lupus. It's not required with certolizumab therapy. So the aim of the study is to determine whether TNF blockade added to a regimen of heparin and low-dose aspirin, those are the treatments that patients with antiphospholipid syndrome, that means patients with the antibody, as well as either obstetric or thrombotic complications associated with the antibody, they're always on aspirin and low-dose heparin, to see whether or not adding certolizumab, that's the TNF blocker, will prevent or reduce the rate of fetal death or preterm delivery due to preeclampsia or placental insufficiency. It's called a phase 2 trial. It's FDA approved. It's NIH funded. The certolizumab is the TNF blocker we chose because it's not transferred across the placenta. It stays in the maternal side. Patients get the certolizumab. They inject it into themselves the way you would heparin from weeks 8 to week 28. And we're going to compare the outcomes to the women in Promise who are the same as the IMPACT women. They have antiphospholipid syndrome and they have a repeatedly positive lupus anticoagulant. Next slide. So what about these women with antiphospholipid syndrome and lupus anticoagulant? In Promise, there were 61 of them. 44% of them had a serious adverse outcome, an intrauterine fetal death or an indicated delivery less than 34 weeks for severe preeclampsia or placental insufficiency. And if gestational age when their pregnancy ended, it was 24 weeks. Oh, sorry, next, just click again. And if you look at the survival of the offspring of those 61 patients, only 70% of them brought home live babies, and many had spent a long time in a neonatal ICU. So this is a really high-risk group where the risk-benefit of being in a trial and getting a medication makes a lot of sense, I think. Next slide. So what's happened with our IMPACT trial? It was started in 2017. It took a while to get going. We have enrolled 42 patients. It's taken us, as you can see, many years. We've continued to enroll through COVID. And I will give you a few bits of information about the study. It is not done. So by no way am I saying this therapy should be used. It should not be used till we know it meets the endpoint of success, at least in this trial and maybe in subsequent trials. Slide. So the way you get into IMPACT is you get in touch with me or with Dr. Branch, who's an obstetrician and maternal fetal medicine expert in University of Utah in Salt Lake City, and we can send you their contact. You or your doctor, before your pregnancy or when you just see the plus sign at home, contact us. We screen you, see whether you meet the criteria, see if there's any contraindication, and we manage the trial. We send you your medicine. We talk to you every 2 weeks, ask you a lot of questions about how you're doing, and your doctor sends us your records and is part of the team, but isn't a researcher. Next slide. So we don't intervene with your care. So what are the results so far? We've enrolled 42 patients. 5 of them had very early losses or genetic problems, so they're really not interpretable. Their complications had nothing to do with trial. So 34 patients completed their pregnancies, and 27 of the 34 did not meet the primary outcome. They had uncomplicated pregnancies with healthy babies. 7 patients met the primary outcome. There were 3 intrauterine fetal deaths with 1 early preeclampsia. There were 4 preeclampsias that occurred less than 34 weeks, but all of them were more than 30 weeks, and all of them had live babies. So 21% met the primary outcome compared to 44. We've cut it more than in half. And the next bullet, and I think is the most important, please, next bullet, is that of the patients in IMPACT, 92% of them brought home healthy babies, compared to the 69% that didn't have our intervention. The next slide. So I think what I've shown you in brief from a scientific standpoint is we can predict complications, not 100%, but we could have a sense of who may have problems and who is highly likely to have a very straightforward, calm pregnancy. I'm not saying don't get followed closely, but rest comfortably and don't fret. And we can also try to prevent the complications in lupus and APS. And this is the first trial. I hope there'll be more trials. And I hope in the next year, we'll have the results of IMPACT and be able to really influence care. One more slide. I have to thank all the patients in my studies and my collaborators. We had no dropouts in a study where patients are either given a drug or in an observational study, and you have to give blood and get phone calls every 2 weeks. The blood is once a month. Next slide. And these studies are very labor intensive. They take a lot of investigators. They take a big team of coordinators, doctors, data processors, and the NIH and the Lupus Foundation has made substantial contributions to enable us to continue this trial. So I'm grateful to them, and the drug company has given us the medication for free, where it would cost $15,000 to $20,000 a patient to take it from week 8 to week 28. So now I think we're ready to take all sorts of questions for all of the panelists.
Thank you so much. That was great. And yes, we are ready to do the Q&A portion. If I can invite everyone back on to their cameras and unmute themselves. And while we do that, Dr. Salmon, I saw in the Q&A, someone was looking for the information for your clinical trial. So if you have an opportunity, if you don't mind popping that in there, or maybe in the chat where they can find the more information for that.
Put it in the chat.
That would be great. Well, I know we don't have a lot of time, but we've had a lot of great information this evening. So I'm going to get started with some questions I was jotting down from the chat and the Q&A. And Dr. Buie, I'm going to start with you. And I know you answered this already, but I think it's great information. Someone asked what your diet was like.
Sure. So I mainly consumed a diet that was high in fruits and vegetables, healthy fats like nuts and avocados, as well as lean meats. So things like lean turkey breasts, chicken breasts, etc. But I think, the key for me, because I dealt with issues, the kidney disease, as well as blood pressure issues, as Dr. Salmon alluded to, in African Americans, we tend to have higher rates of blood pressure, and some of that is salt induced. It was the reduction in sodium that I believe worked to my benefit and helped me not only lose weight, but also get off of one of the ACE inhibitors that I couldn't be on during pregnancy. So, and then also water was a huge component, drinking lots of water.
Thank you. Yes, I think that's helpful information. Another question that I saw was asking about the impact of IVF on lupus patients. And I don't know if either of you would like to address that. Have any information?
Yeah, I can take a stab at it. What we say to patients is that this sort of same parameters are like, we don't want patients with very active disease to undergo IVF. At the time of IVF, the disease shouldn't be very, very active, because that stimulation is going to potentially make things worse. But that's really the only restriction. Assisted reproductive technology is compatible or can be done in lupus patients. Somebody also asked a question about ovarian preservation, freezing ovarian tissue or freezing eggs, and it's the same thing. You can freeze eggs, and the nice thing to know about assisted reproductive technology is you can undergo it while being on medication. So if you want to freeze eggs, or you want to do embryo freezing, you can be on things like mycophenolate mofetil. You obviously can't if you're going to get assisted reproductive technology, or say IVF and an embryo transfer. But if you're not getting an embryo transfer and you're saving your embryos or your ovarian tissue, you can do that while you're on medications like mycophenolate mofetil.
Great, thank you for answering that. And then I'm going to kind of combine a couple here because there's a lot about planning. So people asking about, how long they should be in remission for before trying to conceive, and how far out should they be planning with their doctor before that? Should it be 6 months? Should it be 1 year?
So when we wrote the guidelines, we made it a little bit vague. Some people said 6 months. There's some data that 4 months in remission is okay. So I guess part of it is, if you're on medications like mycophenolate, and you're going to have to transition, you want to have some good lead time, because you want to be able to transition and make sure you're okay. But there's not a precise time.
Okay, great. Thank you. And then, sorry, I'll give you a second to catch your breath there. Another question I saw was, I'll open this up to all three of you. Can you provide any tips or recommendations for finding an OBGYN or a maternal medicine, specialist that do specialize in working with lupus patients?
My suggestion is to work through your rheumatologist, because I think if your rheumatologist is caring for you and has expertise in lupus, they've probably cared for other patients with lupus who have undergone pregnancies. So that would be the first place to start. If they're not helpful, I think you look for will be maternal fetal medicine, high risk medicine doctors in your community, not a regular OB, but a maternal fetal medicine specialist who specializes in high risk. And I would interview them and ask them, how familiar are you with lupus? Do you understand antiphospholipid antibodies? Is this something you're comfortable with? How many patients have you cared for? And so on. I think you should be bold and make sure the doctor you go to has the expertise you want.
Those
So
are
I could probably tell her story, how she found hers.
Yeah, I mean, I agree 100% with you, Dr. Salmon. I think it's important to consult with your rheumatologist. I was fortunate because I knew the landscape pretty well because I worked at the hospital, but also one of my best friends was an OBGYN. And so she had a great recommendation for me. And fortunately for me, my rheumatologist agreed. But I definitely think if you don't have those resources, similar to what I had, I would start with the rheumatologist. And then, like Dr. Salmon said, interview that person, make sure they know the complications related to lupus, et cetera, et cetera.
And the other point is the rheumatologist and the maternal fetal medicine doctor need to communicate. And they should do it on their own. But if you're seeing that it's not working, you can be the conduit and make sure that they are in touch with each other and they call each other when they need to. Usually they do.
Absolutely. Actually, and I forgot to mention that when I was speaking earlier, my rheumatologist and my maternal fetal medicine doctor actually disagreed on the medications that I should be on because my MFM had concerns about me being on Imuran while I was pregnant, because she thought that it could cause issues with heart development. But my rheumatologist came back and said, no, we are not taking it out. Because this could definitely lead to, something that we wouldn't want to happen. And so ultimately I trusted my rheumatologist's decision and went with her.
I want to make a point on that because there's been some questions in the chart. There's often discordance between what's in the package inserts and what people think from what they've read in packages and what's the truth. When we got together and wrote the reproductive health guidelines, of which Dr. Salmon was also a participant, there were 30 experts and there were thousands of articles that were reviewed. And so when we made those conclusions, they were really based on a lot of expertise. So for example, the thing about Imuran, the data on Imuran is that the problem is the FDA rated it as a dangerous drug. So people still are sometimes hesitant to use it, but there are literally hundreds of thousands of women who've had organ transplant who have had safe pregnancies on azathioprine. So some of it is some people, they're going to go to the package insert. There's a question about this on the Benlysta, but that's not the most up-to-date and sort of conclusions that people have made. So just be wary of that. Because sometimes you'll have what Dr. Buie has. I've had that happen too. Like I've had, an OBGYN take a patient off of high Plaquenil, and there's like, we want our patients on Plaquenil. And that's happened to me more than once because sometimes people don't, that's not what, they don't know the latest.
And another really important point is, I think women who, as soon as they become pregnant, their reflex is, I'm going to stop all my medicines. Potential not to do that, because if your lupus flares, you're going to do more harm to your pregnancy than your medicines if they're non-teratogenic, which you can call your doctor and discuss that straight on. Theoretically, you should do it in advance, but in general, don't just stop all your medicines. Figure out which ones to stop and which ones not to stop.
This has been a great discussion, and this has all been such good information, and I appreciate you all chiming in on that. I know that I see the chats, everybody's so appreciative of this information, and unfortunately we're out of time. So if we didn't get to anybody's questions, I know you guys were busy answering in the Q&As, but if you didn't get to those, please feel free to reach out to our health educators as well. But thank you so much to our speakers for joining us, and thank you for tuning in. We appreciate you from taking the time from your busy schedule to join our National Lupus and You education event. And we hope you found tonight's information helpful. For more information, you can visit our website at lupus.org or contact our health education specialist.